Good evening. We will start immediately right now. One of the very important sessions, maybe the most important session today, which is the joint session between the Egyptian Society of Cardiology and the European Society of Cardiology. I think the collaboration between the two and the cooperation between the two societies is at the best time nowadays. It's my pleasure to chair this important session with Professor Dr. Amr Youssef, Professor Dr. Jamila Nasr, Professor Dr. Hamza Abil, Professor Dr. Khalid Said Al-Mawrabi, Professor Dr. Muhammad Satiha, Professor Dr. Sameh Shaheen, and Professor Dr. Tamer Mustafa. In 1 hour, I think that we are going to hear a state-of-the-art science, and I will leave Dr. Sameh Shaheen to introduce the first speaker, Dr. Hussam Hassan.
Bismillah ar-Rahman ar-Rahim. طبعا our first speaker will be the chairman of this meeting, Professor Hussam Hassan. One of the chairmen of this meeting, Professor Hussam Hassan, Professor of Cardiology at Sute University. He will give us an update on the 2023 ESC guidelines for the management of acute coronary syndrome, the key messages. Professor Hussam.
Thank you, Professor Sameh. This presentation is about the ESC guidelines, the top 10 messages of acute coronary syndrome guidelines. The first message for these guidelines is one guideline for all acute coronary syndromes. As you all know, acute coronary syndromes represent a diversity of clinical presentations ranging from asymptomatic presentation up to cardiogenic shock or even cardiac arrest. These presentations can be classified according to the cardiac enzymes and the ECG into either STEMI, unstable angina, or non-ST segment elevation myocardial infarction. All of these presentations share a common pathway for management. As you see here, initial assessment, classification, and then all diagnoses go through a common pathway of management. Think of invasive treatment with different indications according to the diagnosis, and antithrombotic therapy, antiplatelet therapy, and anticoagulants, and decision of revascularization, whether by PCI or CABG. And lastly, after passing the acute phase, think of secondary prevention of these patients. The second message in these guidelines is the recommendation of out-of-hospital cardiac arrest. The recommendations are class 1 indication, evaluation of neurologic prognosis no earlier than 72 hours after admission is recommended in all comatose survivors after cardiac arrest. This is class 1. Transport of patients with out-of-hospital cardiac arrest to cardiac arrest center according to local protocol should be considered class 2A. The guidelines changed the recommendation of therapeutic hypothermia, of keeping the temperature of the survivors of cardiac arrest who are comatose between 32 and 36 as class 1 indication in the previous guidelines to just active prevention of fever with preventing temperature from rising more than 37.7 in those patients. Class 1 indication also. The message number 3 are recommendations for invasive strategy. The guidelines kept the 120 minutes rule for first medical contact to wire passage from the previous guidelines. In primary PCI center, the timing should be 60 minutes. In non-PCI center presenters, the time should be less than 90 minutes for transport to a PCI capable center, if not thrombolytic therapy, and then transfer to a PCI capable hospital for pharmacoinvasive strategy. The duration of symptoms for primary PCI in STEMI patients is class 1, less than 12 hours, from 12 to 48 hours if the patient is still symptomatic, with active ischemia or hemodynamic instability as class 1 indication. Otherwise, it is considered class 2A as a routine primary PCI for those patients. It is contraindicated to do primary PCI after 48 hours according to these guidelines. In non-ST segment elevation myocardial infarction, the indications for intervention are very high risk population with confirmed diagnosis of non-ST elevation, and those with GRACE score of more than 140, with transient ST segment elevation, or those with dynamic ST segment or T wave changes within 24 hours. And in high risk population, early intervention less than 24 hours is recommended for those patients who are considered a high risk. For very high risk, those with hemodynamic instability, acute heart failure, life-threatening complications, immediate PCI. These guidelines removed some patients that were present in the previous guidelines, like those with previous PCI, previous CABG, with chronic kidney disease, from the recommendation for early invasive assessment. And otherwise, these patients will go for selective invasive strategy. The message number 4 are patients with multivessel disease and acute coronary syndrome. If cardiogenic shock is there, it is class 1 indication to do immediate PCI to the infarct-related artery only, and do staged revascularization for the remaining vessels within the hospital admission, class 2A. In STEMI patients, the recommendation now, this is new, complete revascularization either during the index procedure or within 48 hours, 45 days. It was class 2A in the previous guidelines, and this is based on the results of complete trial. In non-ST segment elevation patients, complete revascularization is class 2A, and functional invasive evaluation of non-infarct-related artery is class 2B. Message number 5, the recommendations for antiplatelet therapy. In STEMI patients, anticoagulation with unfractionated heparin is class 1, enoxaparin is class 2A, and bivalirudin class 2A, while fondaparinux is contraindicated. In non-ST segment elevation MI, if intervention is planned in the first 24 hours, is class 1 unfractionated heparin and enoxaparin class 2A, while if more than 24 hours, fondaparinux is class 1 indication. For antiplatelets, routine preloading with aspirin is class 1, while it is class 2B, routine preloading before knowing the anatomy with other P2Y12 inhibitors. In the recent guidelines, it is class 2B and contraindicated in non-ST segment elevation patients. Preloading if angiography is planned in the first 24 hours before knowing coronary anatomy. The choice of P2Y12, it is class 1 to choose prasugrel or ticagrelor over clopidogrel. Clopidogrel only if it is not tolerated or not available, prasugrel or ticagrelor. Prasugrel is preferred over ticagrelor as class 2A indication. 12 months, that strategy is the default strategy, it remains the default strategy, and after this, aspirin alone is class 1 indication. There are some deviations in some patients with high bleeding risk to stop the dual antiplatelet therapy and continue on either P2Y12 or aspirin after 1 month, class 2B. In the absence of high bleeding risk, in some situations who are not having high ischemic risk, you can switch also as class 2B after 3 months or class 2A after 6 months. De-escalation, it is contraindicated to be done from prasugrel or ticagrelor to clopidogrel in the first month. This class 3 to be done in the first month. This class to be done after there if there is high bleeding risk or old acute coronary syndrome. You have to remember here that most of the trials about high bleeding risk excluded patients with high ischemic risk. They neglected high ischemic risk in the analysis. This is why, and they were non-inferiority trials. This is why the recent guidelines are cautious about removing or the downgrading of the antiplatelets. Message number 6, recommendations for antithrombotic therapy in patients indicated for anticoagulation. In those patients, the standard strategy is triple antiplatelet, triple therapy with dual antiplatelet therapy and anticoagulants. preferably NOAC in the first week, and then continue on DAPT and single antiplatelet therapy until the 6 months. If there is high bleeding risk, you can use monotherapy of NOAC class 2B. Otherwise, you should continue for 1 year. Also, to reduce the ischemic risk, the recommendation as class 2A to continue for 1 month on the triple therapy and then dual therapy with NOAC plus aspirin. And after 1 year, it is monotherapy with just NOAC for all patients. It is contraindicated to use ticagrelor or prasugrel in triple therapy. The message number 3, in association of comorbid conditions, aspirin is not recommended with platelet count less than 100,000. Clopidogrel with platelet count less than 30,000. And prasugrel and ticagrelor with platelet count less than 50,000. Blood glucose level should be tailored to prevent persistent hyperglycemia. The old guidelines recommended keeping blood glucose more than 180. The recent guidelines just to prevent persistent hyperglycemia. Message number 8, long-term strategy. The long-term strategy of the patients, you have to plan a long-term strategy and arrange outpatient department review and discuss the patient goals and the preferences to give the long-term therapy with 3 goals. The first goal, to support healthy life education, smoking cessation, healthy diet, regular exercise, healthy weight, and psychological management. The second target is to continue optimal pharmacologic therapy, antithrombotics, lipid-lowering therapy, influenza vaccination, promotion of drug adherence persistence. And the third target is to reach the sustained target for blood pressure and LDL less than 55 and hemoglobin A1C of less than 7%. Adding a second antithrombotic therapy, dual antiplatelet therapy after 1 year for secondary prevention is class 2A in patients with high ischemic risk, class 2B in those with moderate ischemic risk. P2Y12 inhibitor monotherapy is considered as in place of aspirin is class 2B. Intensifying of lipid-lowering therapy during the index acute coronary syndrome, of course, this class 1 low-dose colchicine to be considered, particularly if there is other risk factors. Insufficiently controlled class 2B, combination therapy with high-dose statin plus ezetimibe class 2B, and the up-titration from statin, ezetimibe, PCSK1 inhibitors are recommended in these guidelines. The message number 9, recommendations for imaging. Emergency transthoracic echo in patients with suspected acute coronary syndrome presenting with cardiogenic shock or mechanical complications, of course, is class 1. However, in the absence of this emergency TEE, as a triage in the diagnostic in uncertainty is class 2A, provided that this will not delay transport of the patient to cardiac catheterization, while routine CT in acute coronary syndrome patients is class 3. The use of CT has been downgraded from class 1 to class 2A in patients with suspected acute coronary syndrome of uncertain diagnosis, no ECG changes. Incorporating CT as a non-invasive test is downgraded to class 2A. And also CMR in patients who cannot be accurately diagnosed, poor imaging by echo, is class 2B. It was downgraded from class 2A to 2B. The last message for patient recommendation for patient perspectives. You have to discuss the therapy with the patients, and the take-back technique is recommended to explain new concepts for the patient, ask the patient to repeat, and then review the points missed by the patient, and then re-ask the patient to repeat again. This is very important before letting the patient to go home to be sure that the patient will be compliant to secondary prevention programs. Thank you very much.
شكرا دكتور حسام. طبعا مهمة صعبة جدا ان انت تلخص الجايد لاينز اللي في 60-70 صفحة into يعني 10 minutes، لكن 10 messages واضحين جدا. يعني عايز أسأل سؤال. What's your main يعني message that changed your practice لأن وجهة النظر الأولى بتقول يعني ما فيش major changes في الجايد لاينز دي. يعني أنا مثلا في رأيي إن المحافظة على إن الديوال أنتي بليت ثيرابي for 12 months بالرغم إن كل الترندز الجديدة to remove aspirin and to sacrifice aspirin from the very beginning، لكن still recommendations زي ما حضرتك قلت في الجايد لاينز that the practice is 12 months unless there is a high risk of bleeding. فيعني
هو السبب يمكن the explanation for this, as I mentioned, is the design of the studies that recommended the shifting from this strategy to single antiplatelet or shifting from the dual antiplatelet therapy to monotherapy are mainly non-inferiority studies. In most of these studies, patients with high ischemic risk were excluded actually from the beginning. This is why the guidelines didn't rely in these trials much for exclusion of this strategy and for down-regulation of the strategy of dual antiplatelet therapy. This is the explanation that was mentioned actually in the guidelines.
تمام. I thank you very much and I think we leave for the second.
دكتور حسام شكرا جزيلا ناصي على التجميعة الجميلة. بس دلوقتي امتى نضيف كولشيسين؟ يعني امتى نضيفه مع الستاتين؟
Class 2B indications for those patients.
هل في particular items نضيفه فيها؟
Associated remaining risk. Patients with associated remaining risk. There is no particular recommendations actually, but this class 2B.
Thank you very much.
شكرا دكتور حسام للبرزنتيشن. Thank you very much. We should shift to the next speaker, Professor Locher. Locher, yes. From Switzerland. Is it here?
Yes.
Okay, Professor Locher.
Do you see my slides? Do you hear me?
Yes, yes.
And do you see my slides?
Very clear, yes.
Very good. Okay. So I have a bit of a different title on antithrombotic therapy in ACS default and alternative strategies. I have worked with many companies in the past that have worked in this field, but this is not relevant for this talk. So when we look at different thrombi, we can of course have venous thrombi in the lower legs, cable vein. It may go through the PFO or cause pulmonary embolism. And on the arterial side, we have in particular left atrial appendix that we have to consider. Left ventricular thrombi in STEMI and non-compaction on the aortic valve and so forth. So this has been summarized in detail because I don't have the time here in this article published in the European Heart Journal 2.5 years ago. And basically, it reminds us on the fact that we have platelets, that we have factor 10 inhibitors, and of course now also factor 11 inhibitors that are of course of interest. Speaking about aspirin, I just wanted to remind you that in primary prevention, it doesn't work. But if you have really an ACS, a STEMI, in this very instance, there is an old trial, the ISIS trial, that showed a remarkable reduction in mortality early on. And that shouldn't be forgotten. And this has been already discussed in detail by my former speaker in this session. And here you see that we have lots of options to use either dual antiplatelet therapy, single antiplatelet therapy with different P2Y12 inhibitors such as prasugrel, clopidogrel, and ticagrelor. And I think this schematic is very useful for clinical practice. There is new stuff on the horizon. The subcutaneous selatogrel inhibits platelet aggregation in patients with acute myocardial infarction. This is a product that's currently tested in a large trial, and the idea is to inject it subcutaneously to have quick antiplatelet effects when patients at the first moment have pain And so the trial really provides a pen for the patients that are high risk for a reinfarction to inject it whenever they have a prolonged angina pectoris. And here you see in the panel that it actually inhibits platelet function very substantially within minutes. And in pig models, this has been shown to prevent really coronary occlusion. So there's a huge trial now, the SOS AMI trial with 14,000 patients at risk of AMI that we will hear shortly. So, of course, without plaque rupture, there is no thrombus, and without thrombus, there is no infarction. So it is crucial that we consider atherothrombosis versus bleeding, dual antiplatelet therapy and how long, and aspirin or P2Y12 receptor blockers, or even triple in patients with atrial fibrillation. So one important thing is that there is an individual propensity to have solid clots. This is a super study published in the European Heart Journal on impaired endogenous fibrinolysis in STEMI. And you can see here that some patients have a long lysis time, like the one on the right. They have very solid clots. They have a lot of fibrin building, while others have very short lysing times. And there are even patients that have such short lysing time that when they're on the table, they have transient STEMI. So this is very important. And here it shows that this actually is crucial. If you're above and below median of lysis times, you can see that the probability of an event-free survival is hugely different in those that have prolonged lysis time. So this is something genetic for patients. And in the future, we will actually look at this again. You may remember the Atlas ACS TIMI51 investigator trial with rivaroxaban run by Gene Brownwald and Mike Gibson. And you can see that with a very low dose of rivaroxaban, there was actually a significant reduction in events. However, there was also increased bleeding, and that's why I never made it to clinical practice. But I think in the future, we have to look at personalized anticoagulation after PCI. When you have very short lysis times, you will only bleed when you get a little of a NOAC. However, when you have very prolonged, very severe fibrinolysis times, then it may be that this could be a new option with a low dose NOAC, and this certainly has to be looked at in the future. So understanding the thrombus firmness may be the basis for personalized anticoagulation in the future. Now, of course, a major problem are patients that have at the same time atrial fibrillation and ACS, and often they have a thrombus like the one you see here. And of course, some patients also have had atrial fibrillation in the past, and you don't see it. But now with artificial intelligence, when we see a patient, they can actually determine that with a ROC curve in the range of 0.9, that he had previously atrial fibrillation. So we're much better at that. But what do we do when we have such a patient with a thrombus? Of course, there's a big chance of a stroke that we fear a lot during such a procedure. And therefore, what do the guidelines say? Combining antiplatelets and oral anticoagulants has a 1A, and it says as the default strategy for patients with AFib, a JET-VASC score over 1 for males and 2 over women for women after up to 1 week of triple antithrombotic therapy followed by the ACS event, dual antithrombotic therapy using NOAC and the recommended dose for stroke prevention, preferably clopidogrel, is recommended for up to 12 months. So which NOACs would be most suitable for such an approach? These are the NOAC trials with dabigatran, rivaroxaban, apixaban, and then doxaban. And you can see that in the Aristotle and then Engage trial, they had the lowest rate of major bleeding with a similar stroke and systemic embolism rate as oral anticoagulation with warfarin. So these are the preferred ones one should consider. Now, in some patients, we cannot use anticoagulation, and we should consider LAA occlusion in atrial fibrillation in such patients with contraindications to anticoagulation. And you can see this is a meta-analysis of a few trials that overall it seems to do quite well compared to anticoagulation. There is a new technique that's left atrial appendix occlusion during surgery to prevent stroke in the Laos trial. And here, in spite of the fact that even the ones that did not receive an occlusion but were anticoagulated, there was a significant 33% reduction, relative reduction in stroke and systemic embolism in these patients. So this is something to consider in those on-the-go surgery. Then, of course, some patients may not only have a clot in the left atrial appendix, such as this one on the right, but on the left also a clot in the PFO. And here, of course, when we have this as well, and this can actually cause embolic coronary occlusion, rarely so, we can, of course, occlude the PFO. Fortunately, embolic ACS are not very common, but they do occur. And here is the evidence for catheter-based closure of patent foraminal valley. And you can see, as regards to stroke, the event rates are markedly reduced with this interventional technique to an really impressive event. So thus, PFO occlusion is superior to conservative management in those that have such a feature in the secondary prevention of embolic stroke results of 0.63 and up to 2.3. Then finally, of course, patients that come late with huge infarction, such as the one on the left, you may actually have a thrombus in the left ventricle, and you can see it on the right in this MRI. Now, fortunately, with PCI, the left ventricular thrombus in anterior myocardial infarction has declined substantially. As you can see, the temporal trend of thrombi incidence before and after the introduction of PCI or primary PCI on the left with different studies. And overall, you can see that initially before revascularization, up to 33% of patients had actually a left ventricular thrombus. And now this is much less common, up to 10%. However, if you do an MRI, it may be a little bit more, but it's really much less of a problem, fortunately. And now the question is, can we use any oral anticoagulation? The Commander trial tested rivaroxaban in a slightly different patient population with heart failure, but in sinus rhythm and with coronary disease. And to our surprise, there was no effect whatsoever, although a sub-analysis suggested some protection of stroke, but the cumulative event rates were very similar. Finally, we have aortic stenosis. And of course, here, the question is also what to do here. If a patient has ACS and aortic stenosis, we need warfarin, because this trial, that is the REALIGN trial, showed that NOACs are actually inferior to oral anticoagulation. So we have to use warfarin. It remains the treatment of choice for mechanical valves, be it with or without ACS. And finally, HALT, hypoattenuated leaflet thickening in TAVI patients, can also be coexistent with an ACS. And here we tried also a NOACs, but unfortunately in the Galileo trial, there was actually more bleeding and more primary events. So this should remain with antiplatelet therapy. So I had to be very short, I'm afraid. If you want to know more about what I think about this topic, this is the manual I shortly published that is very comprehensive for any disease in the cardiovascular medicine. You might use evidence when rounding. Thank you very much for your attention.
Thank you very much, Dr. Thomas. This is Nabil Farag, President of Egyptian Society of Cardiology. I would like to welcome you here, and we wish to see you physically next time, inshallah. The attendees who don't want you, Dr. Thomas is President-elect of the European Society of Cardiology, and we have the honor to have you with us today, Dr. Thomas. Thank you very much.
My pleasure. Thank you very much for the invitation.
Dr. Magdi Abdel Hamid, he wants to ask you a question.
Professor Lusher, this is Magdi Abdel Hamid. Thank you so much thank you so much for joining us today. We are missing you here in person, but I think next year you can make it. A short question regarding AI. Is there a role for AI in predicting bleeding events to be used for antiplatelet therapy in high-risk patients? Do we have any data about
Yes.
Yeah.
Very good question. I think artificial intelligence and machine learning is extremely good in predicting events, be it bleeding or ischemic events. In the PRAISE trial, they specifically looked at this. My former fellow, Fabrizio D'Ascenzo, published that in The Lancet. And I think artificial intelligence is actually changing medicine completely. I invite you to watch my lecture that I gave at the Grand Rounds at the Royal Brompton Hospital on what it does actually in cardiovascular medicine. It is amazing, and it's available on the platform of the Zurich Heart House for those interested.
Yeah, thank you very much, Dr. Thomas, for the lecture. My question about citalopram. Is it replacing the loading dose of the other antiplatelets? Because we should continue in oral form. This will replace this bolus. At the second point,
If I may ask this first, and then you come to your second point.
Yes.
Basically, there is a pen, and the idea is that this is a product for high-risk patients at high risk for a second event. They get they have this in their pocket, sort of, and whenever they have angina, they should inject it to avoid any platelet forming in the coronary arteries. And this trial is currently running. We will see whether this is better than usual care in these very high-risk patients. But it may be, eventually it could be something interesting also in the ambulance because it really works much faster. And initially, when the clot develops, platelet inhibition, it may still be effective. But once fibrin makes the clot solid, this is much less of an issue.
And also, yes.
Professor Thomas,
the duration of action, is it also suitable to bridge for surgery if you in acute coronary syndrome and you refer your patient to surgery? Is it good for bridging to surgery, a short duration of action?
That hasn't been tested yet, but the half-life is relatively short, a few hours, but it depends when you have surgery, of course. This has not been properly looked at.
Professor Thomas, this is Gamila Nasr, Professor of Cardiology at South Carolina University, Egypt, and I'm just asking about the innovations in gene editing. There have been a lot of studies about gene editing, probably in preventive cardiology. Do you think that, what's the future of that in stroke patients?
Well, I think I would say that if CRISPR-Cas9 works in inhibiting PCSK9 once in a lifetime, we can close the Cas labs, but this is not reality yet. But seriously, I think there's now a trial in patients with FH with CRISPR-Cas9 against PCSK9. And in theory, this would be a one shot in a lifetime. And based on what we know from patients that have this missense mutation by birth, the event rate would be reduced by 88%. So in theory, this is a very, very promising new perspective. Also in amyloid heart disease, similarly, the trials are running.
Thank you.
Thank you, Professor Thomas Lucher, for joining us in this very important session, and hope to see you soon in Egypt in physical. Thank you very much for your presence. It's my pleasure now to introduce the past president of the Egyptian Society of Cardiology, the educational committee chair at the Heart Failure Association of the European Society of Cardiology, the chairman of the cardiology department at Cairo University, the president of the Heart Failure Working Group in the Egyptian Society of Cardiology, my friend and brother, Professor Dr. Magdi Abdel Hamid. The session is acute coronary syndrome, and his lecture is management of the post-acute phase. Dr. Magdi.
Good evening, everyone. Thank you so much, Professor Islam, for the kind introduction. Mr. Chairman, dear colleagues. So in a couple of minutes, I'm going to cover management of post-acute phase. I think Professor Lucher and my dear friend Hussam make my job easy because they covered a lot of points that I'm going to discuss. So in short, this is my disclosure. Secondary prevention after coronary event is very important to improve symptoms, quality of life, and it is central to avoid morbidity and mortality, to avoid further events. So we have to explain for our patients secondary prevention and to cover the important points: cardiac rehabilitation, lifestyle management, pharmacological treatment, as we'll see later. So the goals is to support a healthy lifestyle, is to continue optimal pharmacological and cardioprotective medications, and to reach and sustain risk factor treatment targets. So, in short, how to support a healthy lifestyle? We have to talk to patients and to convince our patients to stop smoking, eat a healthy diet, do a regular exercise. A healthy weight is important. Psychological management, because depression is very common after heart attack. At the same time, we have to continue optimal pharmacological and cardioprotective treatment. Antithrombotic therapy, lipid-lowering therapy, annual influenza vaccination, and we have to insist that continuation of treatment and adherence to medications is very important. And we have to reach to the target regarding blood pressure, regarding LDL and hemoglobin A1C. So a systolic blood pressure less than 130 millimeter mercury is needed, as diastolic less than 80. LDL less than 55, hemoglobin A1C less than 7%. So the guidelines recommended that all SS patients should participate in a medically supervised, structured, comprehensive, multidisciplinary exercise cardiac rehab, class 1A recommendation, and regarding the lifestyle management, a class 1B, to stop all smoking, tobacco, and healthy diet, restriction alcohol, stop alcohol, regular aerobic physical activity, reduce sedentary time. And it has been proved that stopping smoking after heart attack can reduce further myocardial infarction and mortality by 30 to 40 years in many clinical studies. So we have new pharmacological therapies which can help our patients to stop smoking. Nicotine replacement therapy, varenicline, bupropion in combination can be used. And I think the anti-platelet strategy was mentioned elegantly by the previous two speakers regarding the default strategy, the continuation of anti-platelet therapy, aspirin and P2Y12 inhibitors up to 1 year. And the same was discussed previously regarding short-term adapt. Always you have to individualize the treatment options, ischemic risk versus bleeding risk. So in high bleeding risk, we prefer to shorten the duration and to continue on monotherapy So this in the guidelines in very high bleeding risk patients, 1 month, 3 months, 6 months, and always consider some scores which can identify which patients who will get a benefit from extended or prolonged DAP therapy in high ischemic risk patients and low bleeding risk patients. Again, also it was mentioned the long-term DAP, the class 2A, to add second antithrombotic agents to aspirin for extended long-term secondary prevention in patients with high ischemic risk and without bleeding risk, and the class 2B in moderate ischemic risk and without high bleeding risk. B2Y12 inhibitor monotherapy is an alternative to aspirin as a monotherapy, but this is a class 2B recommendation. Lipid-lowering therapy is very important to reach to the target LDL. So the guidelines recommended that in patients admitted with acute coronary syndrome who are naive for statin therapy, irrespective of the LDL level, you have to start or initiate a high-intensity lipid-lowering therapy, which is class 1 recommendation. However, combination therapy with ezetimibe, for example, a class 2B recommendation. Patients who are coming on low dose statin therapy, low potent intensity statins, we have to change to a high intensity statin therapy, which is class 1 recommendation, and to consider combination therapy, which is considered also a class 2B recommendation. Patients who are on highest tolerated statin therapy, but the LDL is less than 55, so no change in therapy. But if the LDL is not at the target, you have to add ezetimibe, and this is class 1 recommendation. If the patient's on high tolerated dose of statin and ezetimibe as well, LDL goal is reached, so no change in medications, LDL is still not on the goal, you have to add PCSK9, which is class 1 recommendation. So you have to check patients to the target LDL to reach to less than 55 milligram, and we have different options to reach to the target, starting by high-intensity statin therapy, combination therapy with ezetimibe, and PCSK9. All of us know IMPROVE trial, a very big study which involved more than 18,000 patients within 10 days of the acute coronary event. And those patients were randomized to receive simvastatin alone, 40 milligram, and the other randomized group to receive combination therapy, simvastatin and ezetimibe, looking for the primary endpoint, which was the composite of cardiovascular death, MI, hospital admission for unstable angina, coronary revascularization, or stroke. And we learned from this important study that combination therapy is better than high-intensity monotherapy regarding the primary endpoint, up to 5 years or more, highly statistically significant reduction in the events rates, and the number needed to treat was 50 patients. In addition, also, we have seen a PCSK9 in recent acute coronary syndrome patients. Look for the alirocumab, PCSK9 in patients who develop acute coronary syndrome, and the same rationale, looking for the cardiovascular events, coronary artery disease death, non-fatal MI, fatal non-fatal ischemic stroke, unstable angina require hospitalization, and the outcome also was in favor to add PCSK9 early to achieve the target LDL according to this trial. And this is very interesting. Studies for PCSK9, not only looking for the events or looking for the LDL, but also looking for the characteristics of atherosclerotic plaque. IVUS and OCT guided studies in evolocumab in Pacman acute MI, Huygens alirocumab, and using IVUS and OCT revealed a statistically significant reduction in the percent atheroma volume as well as the fibrous cap thickness. Very interesting data. So the recommendations, as we mentioned, class 1A high dose statin therapy, LDL less than 55, class 1A, ezetimibe should be added, class 1B, PCSK9, class 1A if still LDL is not on the target, and intensify lipid-lowering therapy during the index event. A class 2B, in patients who develop recurrent atherothrombotic events within 2 years of the first event to reach to a much lower LDL, less than 40 milligram per deciliter. High dose statin plus ezetimibe may be considered during the index hospitalization, which is class 2B recommendation. Beta blockers, class 1A, when the EF less than 40, regardless heart failure symptoms. Beta blockers routinely in SS patients, regardless of the ejection fraction, a class 2A recommendation. And RAS blockers, ACE inhibitors should be considered a class 1A in the presence of heart failure symptoms, EF less than 40%, diabetes, hypertension, and or CKD. MRA, according to the trials, eplerenone was associated with statistically significant reduction in mortality. So it's class 1A in ejection fraction less than 40 and heart failure or diabetes. Routine ACE inhibitor for all SAS patients is considered a class 2A recommendation. Adherence to the medications. So polypill is encouraging patients to continue on medications, anti-diabetic drugs, SGLT2 inhibitors, IMBA, DABA, CANA, class 1A in those patients with type 2 diabetes and cardiovascular disease or very high risk patients, and liraglutide, semaglutide, also class 1A for the same indication. Imaging, when to ask for imaging? In patients with pre-discharge ejection fraction less than 40%, we need to repeat evaluation of the ejection fraction within 6 to 12 weeks, which is class 1C recommendation, because some patients needs an implantation of ICD. Cardiac MRI should be considered a class 2A to assess the potential need for primary prevention for ICD. And the class 2B, low dose colchicine, 0.5 milligram once daily in patients who develop recurrent cardiovascular disease events on optimal medical treatment. So polypill in the SECURE trial, combination of statin, ramipril, aspirin was associated with statistically significant reduction in the primary outcome, including mortality. So the recommendations, class 2A, to consider polypill on those patients. So this is the information that we need to talk with patients before discharge, pre-hospital, in-hospital, before hospital discharge, proper prescription of medications which decrease recurrent events after acute coronary syndrome. Thank you for your attention.
As usual, a very elegant presentation, Professor Magdi. I'm just, you're talking about smoking. I think it's a really very important issue. And I think there is now a growing need, a growing, all over the world are talking about the e-cigarettes as well. E-cigarettes, electronic cigarettes, and vaping. And they consider it now all over the world as not as safe as they used to know before. So do you think, you have talked about smoking, do you think that we have to press in our society that to say that e-cigarettes as well are not safe as we used to know?
In our registry for with the ESC, we have seen that more than 50% or 60% were smokers. So in patient STEMI registry, so the smoking in Egypt is very high, and you know that we are seeing patients, young patients who are heavy smoker and they develop acute coronary syndrome. So before hospital discharge, we should encourage and we should discuss with the patients, take more time after putting the stents, not putting the stents, and give time for patients to discuss the risk factors and how to modify the risk factors, lifestyle modifications, drugs for second prevention. So we should refer those patients to a specialist who is
yes. My second question. Sorry for yesterday we have just started to follow up patients with heart failure by using some echo machines, which is artificial intelligence based. You just get the ejection fraction only, and that. Do you think how far you think that we recommendation for this type of follow up of patients by using the artificial intelligence based echo mobile machines?
I think as long as we are in the era of AI, AI now has an important role in cardiovascular disease management, atrial fibrillation, heart failure, STEMI patients. So in those patients, I think AI can guide us for proper assessment of high-risk patients, especially patients who have a low ejection fraction. So the guidelines recommended to repeat the echo within 6 weeks to assess for the ejection fraction, and to do an imaging like CMR for patients who are at high risk for arrhythmic event. So ICD, primary prevention, is important. So AI, I think, will be of value for those patients.
Thank you very much. There is any questions? Thank you very much, Professor Magdi. And we'll come to the next speaker. And I have the honor to introduce a very elegant professor of cardiology. She's a dear friend. She's one of the very distinguished ladies or women in cardiology in Egypt. I do have the honor to introduce Professor Heba Atiyah, the professor of cardiovascular medicine at Shams University. And she's as well very interested in women and in cardiology. She is a member of the working group of women and of the Egyptian Society of Cardiology. And we are very proud. She had conducted a very elegant meeting for the women in heart. Very happy and very proud to introduce my dear friend. We are all proud of you, a legend in cardiology in Egypt. And she's going, of course, to tell us a presentation about gender and gender difference in the management of acute coronary syndrome patients.
دكتورة جميلة, I'm really delighted with this introduction. حقيقي يعني you thrilled me. وبشكر دكتور نبيل for choosing me to replace him in this assigned talk. دكتور Nabil was always supportive, not only as my professor, but also as the president of the Egyptian Society of Cardiology. بشكر أساتذتي for giving me the chance to be among you. دكتور إسلام طبعا هو اللي ابتدى القصة. I'm really proud to be here. I congratulate دكتور حسام حسن وقسم دكتور عمرو وقسم القلب في طب المنيا دكتور خالد على the success of this meeting, being the biggest meeting in the Middle East. Actually, we are going to review some of the data on the gender difference in the management of acute coronary syndrome patients. We will highlight the differences in risk factors of acute coronary syndrome in females, the difference in the pathophysiology, how they present with acute coronary syndrome, and the underrepresentation of females in the current studies conducted or the old studies that paved the way for guidelines, and the outcome of intervention of acute coronary syndrome in females. Actually, the females, they are similar to males and they differ in other aspects. In the common risk factors, the females are more predominant when they have problems in the hypertension or diabetes as they present with coronary heart disease, and the recently added risk factors like depression and also the socioeconomic status. The obesity is more predominant in females, and also when they have hypertension, it is more common in women with myocardial infarction than in men. The specific differences in females does not disappear. Females also, they have a specific risk factors like those with the hormonal changes through their life, with pregnancy, after menopause, if they use oral contraceptive pills for the as a contraceptive method or other methods. Also, the eventful pregnancy increases the risk of myocardial infarction and ischemic heart disease later in life. The non-gender specific risk factors in females like anemia and sedentary life and coronary heart disease, while we have in the gender specific cardiovascular risk factors, they have in addition to all this the hypertensive disorder of pregnancy, the premature menopause and the early menarche, and the gestational diabetes. The polycystic ovarian syndrome is also one of the risk factors for females. The autoimmune inflammatory disease is more common in females, and the hormone replacement therapy. The females, they carry the burden of increased cardiovascular risk through their life, starting from pre or peri-pregnancy. During adverse pregnancy outcome has proved to increase the risk of cardiovascular mortality, and also the early onset menopause. The oncological effects of breast cancer, ovarian cancer, and uterine cancer, and the treatment with drugs for treatment of cancer also carries high risk of associated ischemic heart disease. So do females present with chest pain? Actually, females have a different modes of presentation. Among patients with acute coronary syndromes, fewer women present with STEMI and more present with unstable angina compared to men. An analysis of the GUSTO-2B trial showed that STEMI was significantly less frequent in women, 27% versus 37% in males. In groups of patients with non-STEMI or unstable angina, women were more likely to have unstable angina than men. The higher rate of STEMI in men than in women was later confirmed in a sample of 78,000 patients in the guidelines for coronary artery disease registry. Actually, what happened in the new guidelines of the American Heart Association and the American Cardiovascular Society in 2020 changed the synonym of atypical chest pain, and this was said that chest pain should not be described as atypical because it's not helpful in determining the cause and can be misinterpreted as benign in nature. Instead, chest pain should be described as cardiac, possibly cardiac and non-cardiac. And this was caused by the fact that women who present with chest pain are at risk for underdiagnosis, and women presenting with chest pain, it is recommended to obtain history that it might be of ischemic origin. Usually in the GRACE registry indicated that women are more likely to present with atypical symptoms as nausea than men. Similarly, on a review of large cohort studies showed that the absence of chest pain was more common in women with acute coronary syndromes. Women are also more likely to present with pain in the upper back, neck, jaw, and with weakness, dyspnea, and easy fatigability, with sense of dread more than the typical Hollywood chest pain, holding their chest and sweating, the typical picture that we have of ischemia in our minds. In the Virgo researchers found that women were more likely to have their symptoms initially attributed to non-cardiac conditions by the provider, including acid reflux, stress, and anxiety. Non-cardiac causes of chest pain that must be evaluated in women. If we exclude ischemia, we should look for non-cardiac causes of chest pain. The underlying pathology differs in females than in males. The females, they have smaller blood vessels. When they have the chest pain, they have it with rather non-obstructive coronary artery. In this very nice paper studying the pathology of the coronary artery disease and the difference, they found that we have other determinants for the chest pain in females other than the ischemic determinants, like the spontaneous coronary artery dissection in the Takotsubo carditis in females caused by stress. The females, they have smaller caliber of blood vessel, less black burden, and they tend more to ulcerate non-obstructive plaque. And the females, they usually come with different symptoms. They are misinterpreted. They are guided elsewhere, and they have a higher risk of, when we intervene, of radial spasm and small artery spasm. Compared to men, women with chest pain are more likely to be diagnosed with coronary vasospasm, MI with non-obstructive coronary artery, MINOCA and INOCA, and spontaneous coronary artery dissection, and Takotsubo cardiomyopathy. 10% of all patients, and in up to 1/3 of female patients, no culprit coronary lesion is identified angiographically. The management strategy also differs. Management strategy for acute coronary syndromes was largely been the same for men and women in the studies, while focused predominantly on obstructive coronary artery disease. The risk stratification schemes for acute coronary syndrome in the heart, in the GRACE, in the TIMI, and in the KILIP classification, it was derived from male population and their ability to adequately risk stratify women with suspected coronary artery disease is still debatable. In a cohort analysis of 54,000 patients presenting to Alberta Emergency Department, found that women presenting with stable angina, unstable angina, acute MI, or chest pain were significantly more likely to be discharged than men. They usually discharged. They are not diagnosed as having coronary artery disease. In 2010, a prospective German study of 1,200 patients similarly found that women presenting with chest pain were significantly less likely to be admitted to the hospital than men. Data from the Beacon trial further confirmed that women with suspected acute coronary syndrome were admitted to hospitals at significantly lower rates, 33% versus 42%. The known lower incidence of obstructive coronary artery disease in women may contribute to this admission behavior. However, women found to have obstructive coronary artery disease have significantly higher mortality rates. In addition to difference in hospital admission rate, women experience lower rates of observation unit admission. They don't even admit it to the observation for 48 hours or 24 hours, and they are delayed in hospital admission. A Swedish retrospective chart review of 2,000 patients found that women experienced a delay in hospital admission 36 minutes on average compared to men. And men were 3 times as likely to be admitted to a coronary care unit. Other research carried out in young adults also found significantly decreased rates of hospital admission and rates of observation unit admission in women compared to men. In this view, we see that there are differences in the mechanisms and characteristics of myocardial ischemia in women and men. The fractional flow reserve is different. The difference in the anatomy between women and men. The impact of emotional stress as a trigger in females is more predominant than males. The current guidelines recommended immediate coronary angiography in patients with type 1 MI STEMI, as well as patients with type 1 MI non-STEMI, presenting with refractory angina. An early invasive strategy within 24 hours is recommended for individuals with non-STEMI and stable clinical presentation, but high-risk features according to current gender scores. Whether the lack of 6 specific guidelines or the high percentage of women presenting with different symptoms and comorbidities, we are not sure which of which. The women are less likely than men to undergo invasive revascularization, and they need to determine why is this true. Low adherence to prescribed therapies, as well as underutilization of cardiac rehabilitation and pharmacotherapies in women with acute coronary syndromes has been reported, and the references are here. Benefits of an early invasive strategy is proven for both men and women. While very early invasive strategy within the first 12 hours improved the outcome in high-risk non-STEMI patients, but did not benefit women. Females have consistently been associated with an increased risk of bleeding and vascular complications during PCI. increased risk of restenosis, repeat revascularization, and access site complications in women due to the, as we said before, different pathology, small coronary arteries, frequent occurrence of radial artery vasospasm, and subsequent radial to femoral access crossover were more needed in females. Early cabbage observation studies report higher higher risk for short and long-term mortality following a cabbage in women as compared to age-matched men, even when adjusted for age and comorbidities. Women's smaller arteries, difference in harvesting the arteries, longer time for cross-clamp, less use of internal mammary, as we said, grafts in women, and worse preoperative health status in women as they present with coronary artery disease rather later. And now we see pregnant females coming with acute coronary syndromes, and there's an increased rise in the incidence of acute coronary syndromes in pregnant women. This is due to the recent rise and prevalence of coronary artery disease in the young and perimenopausal women. According to the latest European Society of Cardiology guidelines, primary PCI is recommended in pregnant females with acute MI and STEMI. I think the solution for this problem is increasing the participation of women in cardiovascular trial. In this JACC Council perspective, it was found that the participation preference ratio in females always ranged half that of males, except in the pulmonary hypertension category. In this nice publication about the gender difference in treatment delays, management, and mortality among patients with acute coronary syndrome, a systemic review and meta-analysis, it defined 37 observation studies and 21 randomized trials, and it concluded that women with acute coronary syndrome experience a delay in time treatment more often than men. They are also less likely to be treated invasively. Females have shown worse crude, short, and long-term all-cause mortality compared to males. However, after adjustment for multiple covariates, a less significant gender difference have been observed. Considering the difference between crude and adjusted mortality, it is reasonable to conduct further investigations for females. So to conclude, persistent knowledge gap with regard to the optimal risk stratification management in females of acute coronary syndrome patients, patient and system delay in women with acute myocardial infarction result from limited awareness of the latent cardiovascular disease risk and lack of sex-specific thresholds within clinical guidance, limited performance of diagnostic approach in women, and all of which are the result of persistent underrepresentation of women in cardiovascular studies. Thank you very much.
A very interesting, as usual, very interesting presentation, and enjoyed it very much. It's a very tough subject. You're talking about cardiology book as a whole. Yeah. As well as I add to you that in Corali's study registry, there was again the females after acute coronary syndrome, they develop heart failure as well. And maybe gender will be an outcome modifier in developing heart failure after acute coronary syndrome. Thank you very much.
Thank you very much.
Okay, thank you, Professor Dr. Heba. Because of time, we would like to conclude this very important session. I would like to thank the attendees first. They filled the room, full room. Professor Dr. The speakers, Professor Dr. Hussam Hassan, Dr. Thomas Lucher, the President-elect of the European Society, Dr. Magda Abdelhamid, and Dr. Ebatullah Atiyah instead of Dr. Nabil Farag. And I would like to congratulate Professor Dr. Amr Youssef, Professor Dr. Khalid Al-Maghrabi, and Professor Dr. Hussam Hassan for the success of this meeting. Thank you very much, and we see you in the next meeting.